Hello everyone, and welcome to the Refractive Future Live Roundtable, a virtual event organised by the Ophthalmologist. I'm Alexandra Jones, the editor of the Ophthalmologist, and I am joined by an esteemed international panel of ophthalmic surgeons, including Ben LaHood, refractive cataract and laser vision correction surgeon in private practice in Auckland in New Zealand. He's joining us very early in the evening this time, and he will be chairing today's discussion. We also have Andrea Ang, a consultant ophthalmologist at the Lions Eye Institute and Royal Perth Hospital in Australia, who specialises in corneal and refractive surgery. We have Martin Dirisamer, who's cornea consultant at the University of Munich, the University of Graz, and at Wels-Grieskirchen, and he is the co-owner at Smile Eyes Laser Clinics in Linz in Austria. And finally, Ashiyana Nariani, cornea and refractive surgeon and an ocular oncologist. She is assistant professor in the Department of Ophthalmology at King Edward Memorial Hospital and the Medical College in Mumbai in India. A big thank you to all of our panelists for agreeing to take part in today's discussion. And without further ado, let's get started. Ben, over to you.
Thanks very much, Alexandra, and thanks to the ophthalmologist. It's really nice to be part of this panel with these esteemed colleagues. And I've got to say, after reading those bios, I feel quite inferior that all I do really is refractive surgery. But it's great to be here. And I'll kick things off. The first thing I really wanted to talk about was why refractive surgery is what I would call the place to be for a young ophthalmologist. So for me, I remember talking about when people would ask, what do you want to do? And I would say, I want to be a refractive surgeon, and it was really taboo. You shouldn't be saying that. You should be saying, I want to be a corneal surgeon with maybe a little bit of refractive on the side. But I think that's changing. I think it's becoming its own subspecialty, and people are coming through interested in refractive surgery and wanting to do it. So we'll go around the virtual table, and I might start with you, Andrea. If a young ophthalmologist came to you and said, why should I do refractive surgery? What would be your answer at the moment?
Well, I think my answer would be, I think to be a good cataract surgeon these days, you really need to be a good refractive surgeon. So we're so fortunate in our generation that we've got such amazing technology available to us in terms of diagnostics, the intraocular lenses, our surgical techniques, surgical instruments, that I think the real push is actually to get those excellent refractive outcomes. So I think we're all doing, as ophthalmologists, we all do cataract surgery. Well, most of us do. So I think really to be a good cataract surgeon, you really have to be a good refractive surgeon. And in terms of, I guess, the patient base as well, it is very satisfying what we do in terms of, people might view it as a cosmetic procedure, but it's actually not. It's the work we do is actually giving people a new lease on life, improving their quality of life. And we all know how rewarding it is when our patients are just amazed at the difference, and it's really improved, their ability to do all sorts of things, sports, take care of their children, whatever it is. So I think it's a highly rewarding specialty.
Yeah, I totally agree. Now, Ash, when I was saying about feeling humbled and inferior, I was definitely talking about someone that's come to Mumbai in India and helping people with refractive surgery that maybe have been a bit disadvantaged, and that's you. You must have a different spin on why refractive surgery is a big deal for you and why you'd tell a young ophthalmologist that that's the place to be.
First off, I want to say how grateful I am to be with such an esteemed group of folks here. So thank you for having me. I must say that refractive surgery in the past, we were always considered sort of a field historically where it was an add-on to phaco, add-on to cornea, okay, cornea and refractive surgery, phaco and refractive surgery. And I think we're really fortunate now that refractive surgery has become mainstream as a standalone specialty. The fact that refractive surgery is going to have its own college, in the years to come, in the recent, soon to soon to be years to come, I think that's really exciting and says, you know, volumes in and of itself. But the other aspect too, in the world of, speaking of India, and the underserved and the developing nations, you know, we're dealing with treatment of refractive error. Refractive error, right, is something that we have to realize is actually a congenital defect. And it's one of the most satisfying things that we can do in the international world to be able to treat someone that has refractive error. And so global ophthalmology, actually on a global scale, from India to Africa to Nepal, there are huge movements now taking care of and addressing how do we deal with refractive error in terms of refractive surgery. So I think for a young ophthalmologist, you know, you can be climbing the mountains of Nepal and be doing refractive surgery and treating blindness. So it is very, very exciting, Ben.
Yeah, that's really true. I like what you're saying about how, you know, it's not just going on a mission somewhere underprivileged and taking out a cataract. Now it's saying, I don't want to leave that person +6. I want to make sure they can actually see. So really important. Now, I know it's always hard, last but not least, Martin, after we've had 2 great answers, but is there anything different that, from your point of view, from Germany, from Austria, that, you know, people in Europe, that you say, look, this is where you should go. Don't go do VR, don't do cornea, or maybe you do say do cornea, but go refractive. That's where you should be.
Yeah, well, I just want to add one point, because I think it's the only specialty where we could really help people in our age. So all the other specialties are really treating either younger or either older, but here you can really help friends or family, and they're very, very thankful. And it's although it's not that easy as it seems to be, it is a topic which is I think you said, Andrea, not thankful, you said rewardful, I think you said, yeah. And I think that's the point. And yeah, it's hard to get into this field, no question, but it's certainly worth it.
Yeah, you know, saying that it's hard to get into, I mean, most people that go through med school, go through anything, go through ophthalmology are sort of type A personalities. You want to do well, you want to do the best at whatever you can be. And I remember thinking, if I'm going to be a refractive surgeon, I want to be the best refractive surgeon. So I wanted to find a really good fellowship. They're really hard to find. And I know that the Refractive Surgery Alliance is set up recently, and that's going to be a new sort of fellowship system. But I remember traveling to Toronto to see about that and going to different countries. Martin, starting with you this time, like where would you point someone to find, you know, to start thinking about refractive fellowships, or even someone that already does good cataract surgery but wants to get more refractive training?
Yeah, honestly, it's pretty hard in our countries, because we don't have this classic fellowship system. So it's more based on observerships. So you have to ask to observe for a certain time, and you're dependent on the willing of the head of the department there, if he or she wants to teach you something or not. So that's why I was saying it's hard to get into it. So I think the Americans and UK, I think they do way better, because they have really certain fellowships to get a proper education, to get a proper training there. And here you just have to pick it from there, and then you have to start. So that's what I meant. It's hard to get into. Yeah.
Yeah. Ash, from my point of view, there were some refractive fellowships in the US that I thought, wow, I would love to go and do that. But there's also a feeling that with anything surgical, you kind of want to be hands-on. And America especially had a lot of red tape about pressing that button, you know, putting your foot down on the LASIK machine, that sort of thing. From US training, from your background, was it hard to get refractive training? Did you find it hard to find?
That's a great question, Ben. So actually for me, so I trained at the Duke Eye Center in North Carolina, where I did my cornea, external disease, and refractive surgery fellowship. And for me, we were super, super fortunate to have the greatest of training, great volumes in terms of refractive surgery in addition to our cornea. But the idea of finding a fellowship that has what you want, I feel like in the United States, you do have the opportunity. It's like a mall in a sense, where you get to pick, do I want a little bit more refractive surgery? Do I want a little bit more cornea? Do I want dedicated refractive surgery? Do I want to focus more and have a mentor that can take care of us in terms of cataract refractive surgery or corneal refractive surgery? So you have to ask yourself, where do you see yourself in 10 years? Do you see yourself in private practice? Do you see yourself in a group setting? And make decisions from there. But wherever you choose to go, definitely try and find mentors that will be ahead of the game and be ready to try new things with you. Because refractive surgery is such an exciting field. It's technology, as Andrea mentioned, is something that just keeps on moving. We are in an age of exciting technology. So if we find a mentor where they're ready to move to the next level, okay, what's the next best thing? What's the next best thing? Then when you graduate, you'll already have that mindset to be used to trying new things. And I think that's very important.
Yeah, that's so true. I think friends from other subspecialties have always said, look, if you're looking for a fellowship, find a good mentor. It's not necessarily the biggest name. They might be going away talking at every conference every weekend. You want someone that you're comfortable talking to and saying, hey, am I being a cowboy here? Is this okay? What do I do? Because in refractive, you are trying new things that might not have been tested. What about you, Andrea, from this side of the world? Did you have to travel a long way for finding that refractive fellowship?
Well, I was very fortunate because I did, I guess, corneal and external diseases with refractive element. I managed to, I was lucky enough to go to Cincinnati Eye Institute, work with Ed Holland there. So we also did refractive. It wasn't the focus of the fellowship, but he certainly did laser refractive surgery and cataract surgery. And then also Donald Tan in Singapore. So he also did LASIK surgery. So from that point of view, I think the most important thing was really learning about patient selection, reading corneal topography, respecting the corneal tissue, and patient selection and preoperative, postoperative management, as with most of the surgeries we do. And the actual pushing the button or lifting up the LASIK flap, we can all do that. That's not difficult. So I think as long as your fellowship has the focus on those aspects, I don't necessarily think it is very difficult to get that practical experience of actually pushing the button. But I don't necessarily think that that's so important. And in terms of mentors, I would completely agree. A good mentor, someone who you can talk to, discuss cases, is invaluable.
Yeah.
So it may not be necessary that you need a formal fellowship per se, but certainly if you have people who can advise you and you can turn to for help is definitely good.
And I feel like saying that you don't necessarily want the biggest name, I'm sure that the Ophthalmologist magazine would agree that Donald Tan is the biggest name. Was he there? Like, did you feel that even though he was a very prestigious name out there, he was still someone that taught you and was a mentor?
Yeah, absolutely.
On the spot. No offense to him, I don't,
No, they were both great. I was just very lucky, and just even amongst our Australian colleagues, for us, we're lucky we have the Australian Cataract Refractive meeting where, we sit amongst these, people that we've looked up to, our mentors, and you're sitting, having morning tea with them, and you can ask them, about this case, and I think that's where you actually get a lot of information, is that kind of networking at meetings and just chatting to colleagues.
Yeah, absolutely. Now, Martin, I know that I think you're about to become the full-on professor this year. So, you're not just starting, you've been doing this a little bit. Do you still find that when you're trying new techniques, maybe a new IOL, a new surgery, how do you go about it? Do you still feel like you have your mentors and your supervisors previously that you'll go and bounce ideas off? Do you have a group of friends that you talk to? Like, how do you go about if you're going to try something new? What's your sort of strategy for that?
Yeah, perfect question. Because it's crucial. On the one side, every week they're popping up some new technologies, new IOLs, and everything is new and the best. You know this. And I think you really have to stay on the track that you really follow your personal rules, how to pick certain IOLs and why you pick it and why not. For example, I trust a lot in prospective, big prospective studies and working on differences to other existing IOLs. And maybe I'm not the super early adopter in many things because I just want to overcome the first wave of what's good and bad on these technologies. And I think till now it was a successful way, so to speak. So as you saw in some certain IOLs technologies, yeah, of course we did not always do it right. For example, there was this entry chamber Cachet IOL, as you remember. It was everyone was happy, everyone was lucky about it. It was implanted several 100,000 times, and now it's not available anymore because it causes harm to the endothelium. And I think that's at least with an academic view of this technology, it's our task to filter which technology is perfect for the patient, which maybe has to need some more time or whatever. So I think you could not answer this question in one sentence. It's always an individual decision.
I think there's definitely room for a conservative refractive surgeon. We've got enough of a bad reputation for being experimental that I think even a conservative refractive surgeon is a bit more gung-ho than a conservative VR surgeon. So I think that's a good idea. Ash, thinking about new techniques, some surgeons will travel to India to learn new techniques. You know, I'm not a big fan of the idea of sort of that medical tourism. I know it's to help people in need, but there is also this idea of maybe you would learn how to do smile in India, or maybe you would put in this sutured lens in India. Do you find that trying new techniques in India is sort of easier, or has it been different to when you were in the US?
You know, I'm blessed to have both worlds, a foundation in both the United States and in India, because my mindset in the United States is very academic. And so the idea of having good mentors, it goes back to that, really. If you have someone who can teach you step by step, and walk you through it. And then when you're on your own, you're able to call them in the OR and say, look, I just did this. What do you think? Literally be available at that moment when you need them the most. I think that's critical. So in terms of learning in India or in coming to any part of the world to learn a new technique, I think is most welcome, as long as the mentor that you are training with, suppose you do come to India to train with, is someone that can be excellent at handling complications, because number one, number two, through number infinity is always patient care. The patient should always be taken care of. And so nothing should be at the expense of a patient, but we also are human beings, and we should remember that as doctors, right? We're human beings and we do make mistakes. And being a surgeon is a big responsibility. So if we don't continue to learn, then shame on us. But how we learn, we have to do it very wisely. I did learn smile when I went to India, and under great mentors who have done it so many times over. So I am an example of someone who did learn from coming to India and doing that. But at the same time, then I provided my wisdom from what I learned in the United States. And so it's a sharing. It's a sharing in the global family of ophthalmology.
I know what you mean, and you're doing it the right way. It's a controlled environment. You're you're with the right person. It's not just going over and giving it a go. Yeah.
Absolutely.
Now, Andrea, with new technology in Australia, we're sometimes blessed with getting the latest lenses. You know, things get released very early. We get access to things quite early. It's really nice. But on the other hand, I know that this side of the world, people are a little bit conservative too. And, you know, if your colleagues in your city are not particularly keen on something, but you're giving it a go, it's quite tough. And so how do you find, or how do you go about trying a new technique or technology where you are?
I think, you know, along the lines of what Martin said, firstly, you need to research the product. You know, we always have people throwing different products at us, new lenses, etc. So firstly, I guess, understanding the science behind the product, and also looking at any clinical trials that have been done, any results that are available. And I think it's so important, patient selection. So, you know, with any technique that we use, we would firstly pick patients that would be most suited towards that particular lens, etc., and be very conservative. I think, you know, naturally also with my corneal background, I'm quite conservative. So a conservative approach. And I think with anything that you're starting with, you should always just build things up slowly. So, you know, if you're starting out your career in refractive surgery, I don't think the first 10 patients you see, you should be putting in multifocal lenses. So you probably want to make sure, firstly, you know, that your refractive outcomes are good, you've got a personalized A constant, you know, you're not getting any complications, and then, you know, you might move from monofocals to then, you know, EDOF lenses, and then maybe once you're happy with that, and also just picking those patients that are most likely to have success with that particular lens to begin with. And, you know, I think I'd probably be similar to Martin. I don't think, there are some things I might look at being an early adopter at, and other things you might want to kind of just see the results first. But things where the science makes sense, I think you're more likely to try it tentatively, see what your results are. Also have that open discussion with the patient, obviously, that it's a new lens or, you know, that kind of thing, and see how it goes from there.
Yeah, well, I think really good answer. I think pretty conservative, more conservative than I expected all round, to be honest. But I think maybe part of that is being recorded as well, so that's okay. But one thing I wanted to talk about was young refractive surgeons coming out into the world, being birthed from their fellowship, getting out to treat patients and starting out. The idea of public versus private, solo versus joining a practice. And they're probably two separate issues. So maybe if everyone could give sort of like a quick overview of how they did it, and if they were doing it again, how they would go about it. For me, I came into the post-fellowship world and I went 100% private. So a total sellout, absolute shocker. And I regret that because I really miss the public practice, and I'm going back to that. I miss having a registrar and teaching. But refractive, because all of you have different subspecialties as well, you've got cornea or ocular oncology, lots of things going on, that lends itself to public, but a true refractive trained narrow practice, at least in New Zealand and Australia, it's very limited to getting into the public system. So Ash, what's your experience with public versus private and starting out on your own or joining an established practice?
You know, when I first, this is a what are you going to do with your life type of question. I think this is really the golden ticket as far as asking questions for young ophthalmologists to hear. I think the idea is see what you want to do 5 years from now. So for me, I knew that I wanted to come and serve the underserved. Okay, so then I worked backwards from there. I have this passion for refractive surgery. How do we make that go? How do we make that fit? I started off in private practice, and I noticed that in the refractive surgery world, it was not easy for those that had their own practice. I never established my own because I knew I wanted to go work in the government-based hospital. But I noticed the struggles, and in the midst of COVID, I'm still noticing from friends here that it's not easy because they have to, the loans that they have to pay, the financial burden that is there. It's quite tremendous. So be prepared for the financial burden that comes with it, because it's real. But having said that, that should not be a deterrent for what you want to do finally. It's just a matter of being realistic and knowing that those aspects are out there, more so in refractive surgery than in, say, other subspecialties within ophthalmology. For me, I am going up against a waterfall, because my dream is to build a refractive surgery suite center for the underserved. And that's something that takes a lot of funds, but does not bring back funds. In fact, we are going to go negative. So how do we make that sustainable? How do we keep the quality at the premier, giving the best quality care for the underserved? That's what I'm up against. So the challenges there are maintaining excellence and making sure that people understand, going back to what we previously talked about, that we are taking care of human beings. We are taking care of patients, and excellent quality care is of the utmost importance.
It's incredibly noble what you're trying to do, and if you need 3 refractive surgeons to donate their time,
I've got the 3 of you. I've already signed you up, believe it or not.
No problem, Dash.
No confirmation from Martin, but we'll move on. That's all right.
I took his silence as a yes.
Now, question. I read an interesting statistic that was 90% of ophthalmologists coming out don't stay in their first job that they started at when they leave their fellowship. And that's big, that compared to people that used to have a career at the same office. And I know that I've already made one move, and I think it's, it does seem like a huge decision because of that outlay with refractive. If you are thinking that you're going to start by yourself and you're going to start up a refractive solo practice or with colleagues, it's big money, isn't it? And that can be really off-putting. Martin, where are you at the moment? You look, compared to the public hospitals in New Zealand, it looks like you're in a private hospital.
It's indeed, it's the University Clinic in Munich, so it's super public.
And so what is
excuse, but I didn't find a better room here. Sorry.
It looks very classy to me, so don't worry. What is public, private, and what would be your advice about going it on your own versus joining an established practice in refractive?
Yeah, I think the most, or the easiest way is if you start somehow in public, or if you're able to start your refractive career in the public system, it's safe. You know what I mean? You don't have to take some risks, financial risks or whatever. So you just can start and see whether you like it or not, because it's not for everyone, to be honest. So although it doesn't look like super difficult, but you have to take care of a special group of patients, put it that way, very demanding. I know a lot of people tried refractive surgery in the public, but they said, well, that's nothing for me, sorry. So that's a good way to test whether you like it or not. But somehow public system, at least in our countries, is not very compatible to refractive surgery. So people will not get their LASIK, SMILE, whatever in a public hospital. Of course there are, but there are many few, just a few. Most of the people are in private clinics, and they're specialized on that. So the high numbers are in private office. So for me now, it's a blend. And 2 days in academic, and the rest of the week it's private. And for me, it's okay. And I will go on with that schedule the next years, I think. But to start 100% private, I think that's a very hard way, because at least if you're alone, if you're in a group of people, it might be easier and it might be gives you more safety. But just to start 100% as you, Ben, did I get it correctly? You start refractive surgery 100% prevent. Respect.
Yeah,
Chapeau.
no, a terrible decision, and I wouldn't do it again. Yeah. No, I agree. That I think that was not probably the best decision. If you did it again, Martin, would you do exactly the same, or would you change anything?
Good question. No, I think I would pretty much do it the same way. Yeah.
Yeah, that sounds good. Now, Andrea, are you mortgaged to the eyeballs? Did you go straight out and buy a laser and go out on your own, or what did you do? And would you do it again?
So I'm a mix. I do one day in public, the rest is private, and I am in a group practice. And so no, unfortunately, my mortgage is not too high. So I guess that's the advantage of a group practice. So it's already established. They already had the lasers. And I had mentors there. I mean, the reason I joined this particular group practice was because of pretty much the people there that I wanted to work with. Also, the equipment was amazing, but it was more my colleagues that the collegiality. So I guess that's the advantage of having an established practice there. But then the disadvantages of joining a group practice, as we know, are you have less control over decision making. Less control over decision making about things like equipment, staff. And so there are some, and bureaucracy type issues sometimes as well. But then, the practices there set up, it's easy for you to walk into. But one thing people could consider when they first start out is locuming. So, I know I personally didn't do that because I knew of the practice that I wanted to join. But I know some of my colleagues who've done that, and that gave them a feel to different private practices and how they work and where they'd want to end up kind of being.
That's a really good idea. I hadn't thought of that. I mean, I always think a lot of us are in a hurry to sort of get settled and get sort of moving on, but there's a lot of time to work. We're working for many years.
That's very true.
Andrea, along that same line of joining a practice, when I think of Perth, there's one big name in Perth that I think of, which is Graham Barrett and Refractive. And one thing about I'm not sure if you work with them, I'm not too sure, but one thing about joining a practice and having other refractive surgeons around can be feeling as though you're the child of the practice. You're in someone's shadow, and why would someone refer to you compared to that other person? Not necessarily Graham Barrett. And have you found that at all? Sort of, trailblazing or being the young refractive surgeon in a city, do you feel like you have had to make an effort to step out of the shadow and do something different, or do you feel like it's just grown organically? How have you done it?
So interestingly, I work with Graham Barrett. So I am in the same practice as Graham Barrett.
Yeah.
So in fact, we're direct colleagues. So there's 3 of us in the corneal refractive space in the practice. So it's my honor and privilege to work with him, and also my other mentor there, Steve Whitford, who's an amazing corneal surgeon and refractive surgeon as well. So look, I've just really enjoyed their mentorship, to be honest, and I haven't really thought about being in their shadows, or I think sometimes we underestimate what we have to offer too, because we've just come back fresh from fellowships, or sometimes maybe we are more inclined to look at newer things, newer technologies, but definitely I think personally I haven't felt the need to, I'm very happy to be under Graham Barrett's shadow. So and he's a great person to work with, and I'm not sure I've answered your question, Ben. Sorry.
Oh, no, you're fine. I feel like I've really put you on the spot by bringing up 2 of your well-known mentors with Donald Tan and Graham Barrett. I'm sorry. But all I really meant was, do you feel like you've had to, as a young refractive surgeon starting out, did you feel that you had to sort of differentiate yourself somehow? Or did you not really have to? Just sort of everything was okay, really?
Yeah, I think it's grown organically. It really has. I think, you practice, you build results, you build relationships with your patients, your referrers. You know, there's word of mouth. And I think people don't necessarily, you know, just go for the biggest name. I think they develop a relationship with you, their patients get good results, they refer you more patients. So I think it's mostly organic, but I think as younger surgeons, we probably are also sometimes more inclined to try the new technology. So you can build your name in that way as well. So I'm sure, you know, all of us have tried different technology. Companies, industry approaches you to talk about their product. They see you maybe as the next generation of influencers. So that's also, I think, how you build your name as well.
Yeah, no, that makes sense. Martin, I'm not sure, is there any, in your department, do you feel that there are people you have to differentiate yourself from, or sort of seem like the young hotshot, or are you more at a stage where there are other people in your shadow? You know, what have you had to do?
Well, honestly, it's really true. So we have one senior partner and one junior partner, and I'm more or less in between. So, but I think it's always important that to see the potential of the colleagues and to differentiate somehow. If everyone focus on a special topic more than the other, the whole group has a benefit of this. So I think that's the way to go. You know, it does not make sense to be as good as your senior partner in every field, and it's like a copy. So I think you have to find your specialties and your own topics where you feel well and you grow. And for the group and for the team, I think it makes sense, and you can go further, and can go the next step. And I think that's the point where the more experienced has to see this and to go the same way. And yeah, I was lucky so far with my mentors. So
yeah, I think sometimes sort of like what you were saying, Andrea, that sometimes you come back from fellowship and you can feel a bit junior, or a bit, you know, you're used to these people before you go away on your fellowship. They're your seniors, they're your mentors, and it can be difficult to feel on that same, like you've got a lot to offer as well. But yeah, we do. We've got a lot of new things. Yes, you know, you've got ocular oncology, which there aren't many ocular oncologists out there, so you're already differentiated. But from the refractive point of view, do you try to do things differently to attract patients, or do you do different techniques? Have you adopted new things to try and boost that part of your business?
You know, I think that in terms of the idea of trying to differentiate myself is really not a question. Whatever I'm doing because, number one, I'm passionate about it. Number two, I feel like it can make a difference for my patients. If I'm learning a new technique, it's how is it helping someone else, right? So the idea is that, do I need to try and compete with myself? You know, we have a country of 1 billion people, over 1 billion people. There's plenty of work to go around. Okay, but even in a big city like Mumbai, where there are ophthalmologists down the street, the question doesn't arise, well, okay, this person knows this more than I do, and so, you know, shoot, I better learn something else, or I better one up someone else. No, the idea for me, growing up in a very academic environment in the United States, has always been, how do I learn? What can I learn from you? You know, teach me something. And when I say that to someone else, teach me something, they're like, who are you? Like, why, you know, they don't understand this concept here, because, you know, the idea is let's make money. I'm not about that. I want to learn something new. I want to be better today than I was yesterday in whatever I do. And I feel like every human being is different. Just like that, every surgeon is different. Everyone comes with differences. Even if we think we've graduated from the same program, we're different. We come to different meetings, we learn new things. So everyone has something to share. You know, my residents have something to teach me. Let me learn from them. You know, I'm not trying to be better than them. I'm trying to learn from them. So if I continue on that path, every day is exciting. I'm not competing with anyone else but myself.
Ah, that's a really healthy view. I would love to say that, you know, it's difficult to separate the idea of doing refractive and the idea that a lot of people get into it for it being lucrative and making money. But it's not difficult to separate it, actually. Like you say, if you're doing it for the right reasons, it'll work. So that's one aspect where refractive surgery has changed in the past few years. It has sort of gone from being this cosmetic luxury item, you know, I don't want to wear glasses, I'll get LASIK, to being more a necessity. You know, you do cataract surgery and you want a refractive outcome. And so the refractive career has changed. It's gone from being seen as being a cataract jockey or a laser jockey, you know, someone that presses a button, to being a refined, almost like an art to it. And also you're helping more people. People are aware of it. In Europe, Martin, has the refractive surgery career changed in its sort of in its view and in the career pathway? Is it different to how it used to be? And do you think it's going to keep changing?
Honestly, since I do refractive surgery, I do not see a big change, because at that time when I started, it was more or less, at least in our area, still pretty new. So it was just like popping up something, and so for me it does not really change. I changed my mind a little bit. So as you already mentioned, that there is not only one or two options. We have extremely big amount of options for all kind of refractive issues. And but I think the whole market does not really change. We never had this low price issues as in other countries. Now it comes more and more, but at that time it was not really a big problem. So for me now, I see it as Ashiyana said already. You have to make your best job. You have to always think about it. Would you do this to yourself or to your mother or to anyone else? And is it really necessary to do it that way, or do we have other safer options, better options? And I think that's kind of a key for success in refractive surgery. You always have to think these are healthy eyes and take care of that.
Yeah, I totally agree. The other night I was sort of, I guess you'd call it, moderating a debate on immediately sequential bilateral cataract surgery, and there was a for and against. And in the end, I asked them, well, you know, you're both getting older. Would you have this? Would you let me do bilateral sequential surgery on you? Both for and against said no. And I thought, you know, isn't that interesting? You know, that whole idea of would you have this yourself? It's such an important question. You know, if you wouldn't have it yourself, what are you doing? You know,
I had a relaxed smile, so
hey.
I smile for myself. So it's a strong argument.
Yeah, that's good. Sometimes I feel in clinic when the patients ask me, have you had LASIK? I feel like, well, they'll never know if I am lying or not, so maybe I should just say yes, but I don't. And Andrea, what do you think? Do you feel like Martin, that it hasn't really changed in the last few years while you've been practicing? I feel like since I was a trainee to now, there's been a bit of a change of view, like a little bit more respected refractive surgery perhaps. What do you think?
Yeah, I think we're moving away a little bit from that laser cataract jockey kind of label. I think probably having more women involved has softened that view, because I think, you know, yeah, I think, you know, your classic, you know, refractive person, and the people who usually speak at meetings are, you know, the older white men generally. So I think that's changing a little bit. But yeah, I think what Martin was saying, we just have so much tools in our armamentarium now, so we really just have to, I guess that's what's happening maybe compared to 20 years ago, is that there's so much more technology, and within that technology then there's you know 5 different choices within that technology. Do you do wavefront guided, topographic guided, what are you going to do? And then all these different lens choices, and then there's so many companies making different lenses. So I think from our point of view, we have to be more probably abreast of all the knowledge so that we can make the right decisions for that patient, and you have as many tools possible to make choose the best thing for that particular patient's circumstances. And I think also probably there's been an increase in patient expectations over time as well that our generation will need to deal with as well. I think, people do expect very good outcomes. People expect not to have to wear reading glasses in addition to their distance glasses. So we have to manage that.
Yeah, it's amazing, isn't it? What was once considered an amazing outcome is now, it should be a routine outcome, unfortunately. But yeah, good and bad. Ash, it must be difficult for you because you'll still keep in touch with the American side of things, and in India it'll be a bit different. Do you see the refractive surgery career for a surgeon in your centre changing? Do you think it's changed over the last few years, and where do you see it going?
Yeah, I think Andrea's point was spot on. The idea that we really have a higher expectation to our name as a refractive surgeon. We have to be perfectionists, right? And so that goes back to the idea that the more and more perfection that is expected of us, the more and more difficult it's going to be for young ophthalmologists to get into fellowship, right? Because there is going to be that expectation that you are excellent at what you do, that you are going to give the ideal 6'6", 20/20, 20/15 with perfect ocular surface after surgery. And so it's going to keep on changing. We are going to see waves right now in the midst of COVID. The question really is, from our standpoint, a standstill as far as surgical volumes. I would love to hear about what's going on in your side of the world, but for us, it's life or death. And so right now, we cannot be doing procedures that bring patients into contact with the team and allow for that. But it gives us the gift to be able to plan for how do we build the center, how do we build upon techniques, right? All these excellent webinars that are going on for improving education, I think is perfect for the refractive surgeon out practicing, as well as those that are in refractive surgery fellowship, or those that are interested in going into refractive surgery fellowship. They have all of their mentors on a webinar, so they can just go on to YouTube and find out whatever they want to right now. They don't have to stop their education, or they don't have to think, oh, well, what is this type of refractive surgery fellowship going to be like compared to the other? They can do it right now. So I think that's the exciting thing.
Yeah, that is really exciting. I do miss the physical meetings. I love the mingling and meeting people like you, and just being able to have a chat and ask you like, well, what off the stage, what do you really do? What's the real secret? I really miss that. I miss that a lot. Do you have webinar fatigue, Ash? Are you over them, or not at all? You're still hungry for more?
You know what? I'm doing okay. I'm loving it. I think it's really cool because this is kind of our get together celebration party. We don't get to meet each other, but think about it this way: if we did not have what we have right now, where we have to deal with COVID, where we have to get on webinars, I may not have met the three of you. Andrea, I know, but I would not have met you all, right, to the extent that I have if it wasn't for that. And that's a gift.
Yeah, you're right. I should be positive. Now, the flip side of what you said, Andrea, the expectations, is that patients feel welcome to tell everyone how good or bad we are. There's Google reviews. There are, patients can complain about doctors. I wish I could complain about patients. I wish it could go the other way and I could make Google reviews of patients. They'd be all 1 star. But, that's, getting your reputation out there and maintaining your reputation in the public system is probably more the domain of the young surgeon than the established surgeon. And so like for me, I'm really interested in teaching and research, and a byproduct of that has been working with industry, and that the byproduct of that is doing some speaking and doing some talking and trying new things, and that's good. Aside of that, there's the Google reviews, and I run a very cringe-worthy Instagram page because that's what I've been told you have to do. But part of it, I hate it. But there's sort of this expectation that as a young refractive surgeon, you're on show, you're out there, you're talking, you're kissing babies, you're shaking hands, you're like an American politician. And so, what do you think of all that, Andrea? What are you doing, and what are you doing to sort of help your reputation? Are you buying into all this, or are you like, no, I'll let my work speak for itself? What are you doing?
I think I'm on the latter, to be honest. Like I'm Gen X. Look, I'm not Gen Y. I don't even have Instagram, I'm ashamed to admit, or I'm off Facebook. And
yeah.
no, I look, but I think it's completely valid. Unfortunately, this day and age, you should have, probably a website and be out there and doing that kind of thing. But I think it's what you say. It's building. You can also do it the old-fashioned way. I think just getting good results, getting your name out there from patient word of mouth. I think for me, I'm 7 years out now as a consultant, and I think it's that 5 to 7 year mark, especially, that I found word of mouth is very big. So you can do it that way. I think certainly, I guess, amongst colleagues, speaking at meetings and publishing articles, that's definitely helpful in building your reputation. But maybe someone else wants to speak about the social media aspect of.
I like how you've done it. I like if I see you're speaking at a meeting, I come and listen. So even if it's an international meeting, I'd rather be sightseeing. So yeah, you've done it well. So don't worry. Martin, what about you? In Europe, is the social media side of things and Google reviews, that sort of thing, is that something that's widespread, or is that sort of a young refractive thing? How are you coping with that?
Yeah, it's getting more and more important. Of course, the younger colleagues has how to say, the more comfortable access to this social media as the experienced colleagues. And yeah, I think it's really important nowadays as a refractive surgeon to be at least present on social media. The communication is certainly different than on classic way of communication, newspaper, whatever. It's very fast. It's quick. You have to find your style of communication, but it's exactly the group of people you want to treat, which is attracted to this social media channels. So I think it's a good way. It's a cheap way, actually, if you like. And patients always want to know their doctors. And if they see pictures, they see some interviews, they hear some explanations of treatment, they're super happy about this. And I think, of course, I strongly agree with Andrea. It's certainly possible to do it the old way. But I think it would be easier to adapt to social media to talk to your patient or to communicate with your patients.
Yeah,
I should clarify, my answer is not entirely truthful, because our practice, our laser vision center actually does that for us. So they do the Facebook, they do the Instagram. So it is what Martin's saying is absolutely true. I think the reality of today's age and the generations, the younger generations who are looking at getting LASIK, that they do put importance on that.
Yeah, I know what you mean. One thing you said there, Martin, the presence, having a presence is important. When I left the practice I was at in Auckland, and I was relying on the practice for everything. Suddenly I had disappeared, and so I had advice from drug companies, from colleagues that were like, well, you need something, you know, you need a website or just something that a patient can look you up and be like, okay, he does exist, he's still alive, everything's all right. So even just a presence, I think, is really important. But I have had the occasional patient contact me through social media to inquire about laser, that sort of thing, but it's certainly not waterfalls of patients contacting their doctor through Instagram or anything like that. So I think there is a happy medium. Ash, with a population, like you were saying, of over 1 billion people and probably most of them on social media, is that a form of communication that works for you? Is that something you're into? And also, I suppose, with your causes, you know, wanting to raise funds and wanting to help people in need, is it a necessity to be able to show what you do and what you want to do?
Yes, it is, but do I like it? No. That's the short of, yeah, right? And I feel like everybody put their thumbs up because it's true. We don't like to be out there. I mean, we don't want to do this, but it's a part of the life that we live, right? We as doctors are doing something to help someone else. We don't want to have to necessarily show off for it, but that's what life is right now. We have to have some form of a social media page. We have to have the Facebook. We have to have a website. And those things, fine, we do it. But I would say that we don't have to make that our life, right? So we, you know, the post, you know, you can say to yourself, look, that's just something I have to check off the list. I have to, you know, put something on there. And meaningful, whatever I put on, let it be meaningful, right? But okay, I'm gonna limit it to once a day, you know, and then that's it. That's my 5 minutes of social media a day, and that's it. The rest of my life is taking care of patients and other things that are important, because patients that come to you are going to want to know, like Martin said, something about you. Okay, they're putting their eyes in your trust. And it doesn't have to be like yes, we have to put a rosy, perfect picture up, but they actually love you for who you are, even if it's not all rosy. I don't know about you guys, but I've found that, you know, when things are down and dirty and tough, patients are by your side because they see that you're a real person. And so if you just be yourself and say, you know, this is how it is. You know, Andrea and I were talking about on a separate forum actually a few weeks ago about complications in terms of surgery. And the point was brought up, if we're real, okay, about it, and we're truthful and ethical in what we're saying to patients, they appreciate that more than anything else. And so going from the tangent of Facebook and social media, Ben, to really that's just a part of it. I think really how you're going to get your name out there is word of mouth, patient by patient, doing a great job with the one patient that you have in front of you, and then see that person talk to the next 20 people. And that's how I found it works.
And I think it works especially well with Refractive because someone genuinely is life-changing. They've got this great vision. It's not like, no offense to VR surgeons listening, but you know, it's not like I stuck your retina down beautifully, you know, tell someone about how good that is. This is like, yeah, my vision is great. You know, Andrea did an amazing job. So you should send your patients there too. You know, it is something that does lend itself to word of mouth really well. The other thing I really like that you said was about the honesty. I run a podcast that again, is about being honest with your complications and that sort of thing. And I mentioned that doing vitreolysis, I lasered a hole in someone's retina, and it's not something I'm proud of, but I've never had so much feedback from other colleagues saying, thank you. Like, it's a bit brave of you to say that, and you're obviously a terrible surgeon, but it's but it's really nice of someone to actually openly say, yeah, I messed up. Like, that wasn't my finest hour, and this is what I did, and I wanted to talk about it and get that off my chest. And you know, I think there's probably not enough honesty. It's certainly not with social media, but even in the profession, even in refractive surgery, I like the Oscars meeting. You know, you were talking about, Andrea, that it feels to me as the kind of meeting where we all know each other, you can turn up and you can say, yeah, I've put in these lenses and nah, they weren't great, and that's fine. But there's not many forums like that. Now, total sort of change of subject, bringing it up a bit. It's just a quick question. And Martin, I'll start with you because I know you don't have that much time. You're in the middle of a clinic. But what excites you about refractive surgery right now? Like, if you had to say, what's like one thing that you're just brimming with excitement? You wake up in the morning and you're like, this is exciting.
Well, maybe I don't wake up in the morning and I'm super excited. The first thing is not to think about refractive surgery, to be honest. But I think one excited thing is to be able to offer people a very quick, easy procedure to get rid of a big issue. You know, I hear it in my friend circle. They told me afterwards, if I would have known that before, it's so easy, done in 15 minutes, got rid of this contacts and so on. So yeah, I think, and when I go into my private office and my OR day and say, okay, these people are the next week, they're very thankful. They will say, hey, thank you, it's cool, it's very easy and everything. So, well, of course, the patients itself, but also what I basically find very exciting in refractive surgery is that's a very dynamic field of ophthalmology. So there's a lot of technology. There are a lot of yeah, new things popping up every week, as we already discussed. And yeah, that's what I think pretty exciting. So, and I think this is also maybe part of one of your next questions. What will be which specific things I'm looking forward, maybe? Yeah. So,
what are you predicting? What's going to excite you? If nothing's exciting you at the moment, what's coming?
Yeah, I think some new technology things like yeah, the next step in relaxed smile. So if we get maybe the wavefront guided smile, maybe something like that. Of course, next step in multifocal IOLs without any halo glare, or next EDOF IOLs, however you would call it then. Yeah, that's I think these are the most exciting parts in the next 2-3 years, I think. So I'm looking forward to that. And of course, some maybe more precise IOL calculations. That would be nice.
Yeah. Aren't we nerds that we're excited about more precise IOL calculations? But I know exactly what you mean. I know exactly what you mean. I'd like to pretend to be cool, but I'm a nerd as well. Andrea, I probably overstated the level of excitement to Martin, but not what wakes you up and makes you excited in the morning, but is there anything that excites you about refractive surgery right now? And also getting your crystal ball out, what are you predicting is sort of coming? What's next?
Yeah, I'd echo a lot of what Martin said, actually. I don't think there's one particular thing that super excites me. I mean, there are certain things that I guess I appreciate when I'm at work. Like, I appreciate, you know, the biometry that we have. It's, you know, the level that we're at with, you know, for example, in private and public, it's a huge contrast. Where I'm working in private, we have the IOL Master 700, the Lens Star, and then in public, we were dealing with the IOL Master 500 that couldn't get through, you know, 5%, 10% of dense cataract. So you appreciate, you know, the better technology that you have. And I guess, you know, in terms of operating, you know, I appreciate having a Callisto guided system versus, you know, having to mark with a pen. You appreciate all these incremental improvements. I appreciate the fast excimer laser that we've got, and the, you know, the accuracy of that. In terms of what I'm looking forward to, I am looking forward to the second generation Smile. I think that you know, that the companies are developing, you know, in terms of, I guess, dealing with some of the issues with the first generation, and yeah, new lens developments. The clever people who do research on these lenses and do the bench testing and everything, they're obviously just they just keep pushing the barriers a little bit, squeezing a little bit better optics out of each design. So yes, and more accurate formula. You know, whenever you have a refractive surprise, you think about, you know, what could have been, what could have made this better.
Yeah, absolutely. I'm going to be devil's advocate a little bit and say that I feel like we might be reaching a point where preoperatively we're as good as we can be. And I think people might view this video in like 5 years and be, gee, Ben was such an idiot. Like, we were miles, we still had a long way to go. But I think what excites me is maybe the idea that post-operatively we'll be able to light adjust or laser adjust a lens and you know, really refine that. I kind of feel like we've reached the asymptote of preoperative assessment. I'm sure Zeiss or, you know, some company that makes a biometer will think, oh, we've got whole teams working on that, we've got a long way to go. But I kind of feel like, you know, we're measuring a living tissue. Are we as good as we can get? Are we going to leave that to post-operatively? So that's probably what excites me. But Ash, what about you? Is there anything that that refractive surgery wise sort of makes you excited about each day of work?
Can I just stop you for a second? Unfortunately, Martin has to leave as he has a very busy day with a lot of patients waiting. So sadly, we'll have to say goodbye to him, but we'll carry on the discussion with the rest of the panelists. Thank you.
Nice to meet you, Martin.
Thank you so much. Appreciate it. Bye-bye.
Take care.
Good day. See you, Martin.
All right. Well, Ash, I was just asking you if anything excited you in your refractive day at work, or in your dreams about what's coming for refractive surgery.
Yeah, I love it. So I would agree with the light adjustable IOLs. I'm super excited for the day in which I would have the access for light adjustable IOLs. That's something that's in the pipeline, and I'm waiting for that. And in terms of the work that I'm doing currently, global refractive surgery. I'm waiting for the day when we can start to coin the term global refractive surgery for the underserved.
Cool. What will that look like? Will that look like laser refractive surgery, or will it be lens based, or will it be a combination of both?
You know, when we think about refractive surgery in its, you know, sense of the I should say the initial superficial level of it, we're thinking corneal. But I agree with you. I think that it needs to be both. We need to start to think that in Ethiopia, that we would be able to provide a multifocal intraocular lens for someone and allow them to be able to see without glasses for both near and distance. But and that would probably be easier and less expensive than corneal-based surgery. So I think that would probably be, you brought like sort of a light bulb for me, that perhaps we need to start thinking more for cataract-based surgery first, and then do the heavy investments for corneal-based.
Yeah, I think so. My mentor in Adelaide, Michael Goggin, he was really pushing for low-cost toric lenses to sort of fight the idea that, you know, leaving someone with 3 diopters of cylinder is almost just as bad as leaving them with their cataract. And you know, that's been an uphill battle. So I wonder if a low-cost multifocal might be in that same sort of situation, but there's no reason to not fight and push for it, because I think surely in these places where they can't get glasses, finding reading glasses is not going to be exactly easy, and a lot of jobs and tasks are going to need near vision. So, you know, maybe that's something we can go for.
Absolutely, Ben. And you know, I think that in terms of donations, someone would far more easily come to the table if I say, you know what, I need 3 toric lenses for this, and this case. Wouldn't you be far more ready to put up your hand and say, I'd love to give, rather than sort of like, you know, millions of dollars worth of equipment? I'd like to be one part of that chunk of change. So I think that it's more convincing for getting the individual donor on board.
Yeah, and I mean, this will sound incredibly commercial or even more of a sellout than I usually do, but you know, kind of branding or marketing is always about the story. And you know, for me, I would feel much more emotionally invested if someone asked me, here's this person, they need this. This is all it would cost. I'm much more likely to donate to that than just a general cause. So yeah, I like that idea. Cool.
You know, and Ben, I think part of global refractive surgery, you asked, what do you think of it? I think the final point is that there's so much to do in our own backyard, right? So someone used to say to me, why are you moving to another side of the world when there's so much to do in America itself? Very true, very true. I don't deny that. Anywhere we are, there are people who are in need and will not have the opportunity to get it unless we say, you know what, out of our busy schedule, in 52 weeks of the year, can we not be able to provide someone a toric lens or LASIK at a cost that they can actually afford to make their life a little brighter? I think we can do whatever we can wherever we are.
Yeah, absolutely. The next part I was going to move on to was more about the pandemic. And as you've already said that, you know, the pandemic's massively affected and it's life and death where you are. On the other side of the coin, there's us, me and Andrea over this side of the world. We're doing pretty well. New Zealand's kind of famously sort of broken the back of COVID. The problem is we're stuck. We're this tiny nation in the middle of nowhere, and we're absolutely stuck. We don't know how to get out of it. Similarly, in Western Australia, you're pretty isolated, but it sounds like doing really well. How has it affected your refractive practice?
Yes, Western Australia, we have a hard border, which means you really can't travel in or out of the state for anything but special reasons. So we have community transmission is zero, and we have a handful of active cases from overseas, people returning from travel overseas, and they're mandatory hotel quarantining. So I guess we were fortunate enough to kind of do the lockdowns early enough to get the numbers under control, and certainly we stopped practicing during that period. We just saw emergencies, did emergency surgery only. But now it's pretty much, we're very fortunate, it's pretty much back to normal. And in fact, there's been this higher desire than, surprisingly, a high desire for refractive surgery. And I think it's maybe because people aren't traveling, they've got more time to maybe do things that they were planning on doing, maybe more finances to do that. So actually, it's very ironic, but during this time, we're actually busier than ever. I'm not sure if that's your experience, Ben, because that would be perhaps a similar situation in New Zealand.
Yeah, very similar. And I think it's almost embarrassing talking about this when I'm sharing the screen with someone that said it's life and death where they are. But, you know, we've had people that are as busier than ever with the laser. And it's generally people that have said, look, I was sitting at home staring at the wall in my hotel room or my bedroom for 2 weeks, and I just realized, what am I doing with my life? I just need to get my eyes sorted. Or the other side of it actually has been this massive spike in people just being sick of their glasses fogging up with wearing a mask. So, you know, those things, definitely we're seeing a spike. I don't know how long it'll last. I wonder if there'll be a spike, and because of the financial incentives in this country, at least, it's really just pushed the problem maybe 6 months ahead. So I wonder if there will be a proper dip in so-called luxury goods like getting your eyes lasered or getting a refractive lens exchange. But for now, things are good. Now it sounds like on the exact opposite side of the coin, Ash, things are not so good where you are.
You know, yes, but at the same time, though, you echo a sentiment. I was on a meeting with the Refractive Surgery Alliance founder, and we were talking about this exactly, that, you know, in the United States, refractive surgery is at an all-time high. And it's exactly what you're saying, secondary to the fact that people just don't want to wear a mask, right? And so it's so interesting that that's what's pushing the world of refractive surgery, is just this mask. And so let's make the most of it. If that's what it takes, if that's what is moving people to want to become more independent of glasses, then great. You know, ultimately our goal is to get everybody to have the opportunity should they want it and should they be a good candidate. So I'm happy about that, just not in our part of the world. Yeah.
Now with everything being a bit uncertain, you know, the people, we don't know what's happening, we don't know what the future is. And we were saying earlier that refractive surgery often needs quite a big investment. There's quite a lot of, you know, kit involved for doing refractive surgery. Is that having financial implications for your planning for your future, Ash? Is that making you and your colleagues in terms of setting up clinics or, you know, making future plans, thinking about acquiring new machines? What are you able to even make plans, or are you just saying one day at a time?
Very, very good question. So I'm very fortunate to be in an academic, municipal government-based hospital. So right now, you know, the plans are on hold in terms of implementation, but that's not stopping us at all. Because our plans in terms of blueprints and ideas would probably never have happened if we didn't have this moment or months of pause to say, hey, let's do something new, you know, let's try something new. So this is giving us the opportunity to plan in a big way, which I wouldn't have dreamed about occurring, except for, you know, 10 years from now. It's happening now because of the pause.
That's true. What about for you, Andrea? If things are sort of, they're bouncing back, is there still a feeling of uncertainty where people are still thinking, oh, I know that you know, smile upgrade's coming, but maybe we should hold off. We don't know what's going to happen. Is it affecting your planning?
Fortunately, I don't think it is. I think, you know, we're still looking forward, and I think what Ash said is true. It's a time to kind of, well, not that we have more time now, but we did during that lockdown period. That was the time to kind of, I guess, take stock and reassess and plan for the future, because you know, it's hard to know how this is going to all pan out, especially in Australia and New Zealand. As you say, we're a bubble, like we're so isolated at the moment, but you know, this is going to take years to play out. So I mean, personally, our practice hasn't really been, I guess, affected by that, but I can see how people would you know, worry about the next wave and the next lockdown and the financial implications of that.
Yeah, it's interesting times. Now that's the end of you'll be happy to know that's the end of all the questions that I've got, but we've had some questions that have been sort of asked prior to the webinar that I think we were going to be asked now.
Yes, thank you so much for this really interesting discussion. It's been great. And in the UK, we have just heard that we've got another 6 months of, well, lockdown measures coming up. So yeah, it's not looking positive at the moment, but at least you are seeing, especially Ben and Andrea, you are seeing the nicer side of the pandemic, at least a little bit easier. So we've had a question about the RSA, the Refractive Surgery Alliance. You've obviously mentioned it a few times, but could you talk about it a little bit more in a little bit more detail? How has that made a change for you, Ashiyana? If we could start with you, maybe.
Absolutely. So Dr. Guy Kazarian, who's sort of the mountain that is the Refractive Surgery Alliance, he is someone to know, and any refractive surgeon, young or senior, should definitely get in contact with him. He's someone that is so approachable. And recently I've been asked to join the executive committee of the Refractive Surgery Alliance, and I have to say that they are really spearheading, you know, refractive surgery and putting it on the map in terms of specialties, you know, creating its own fellowship, working to build a college of refractive surgeons. Incredible stuff. There's webinars going on for the senior refractive surgeon as well as the resident. There's a resident webinar series for refractive surgery. So I feel like, you know, we've never had anything like that before. When I was in fellowship, we never had any sort of association or alliance or organization that we can turn to. We do have, of course, the American Society for Cataract and Refractive Surgery, and they do a lot, and they still do in the midst of COVID for us. But Refractive Surgery Alliance is taking refractive surgery standalone to another level, and I am excited in the years to come what they're going to bring for us.
Yes, and I believe that they're moving into Europe and starting to do a lot more in Europe. What about Ben and Andrea? Do you have much experience with the Refractive Surgery Alliance?
I came across it relatively recently. I was talking to Dr. Arthur Cummings, who's a refractive surgery legend from Ireland, and he's someone that I've always read his work because he's easy to understand. He makes difficult things sound simple, and I was moaning to him and saying that, where can I point people, to get a refractive fellowship? It's so hard, if you truly just want to be a refractive surgeon, where do you go? It's difficult. It's just plain difficult. And he said, oh, do you not know about the Refractive Surgery Alliance? We're setting up our own fellowship. This is where you'd get to work with a bunch of refractive surgeons around the world. It would be guided. It just sounded like everything I would have wanted when I was looking for a fellowship. They've actually thought about it, and it's taken a mountain of work to put this material together, and it's ongoing, and it's amazing. And it's something I'd love to join, and I will. But I think at the moment it's probably just creeping into everyone's conscious at the moment. It's probably been a little bit under the radar, but I think it's going to explode, and I think it's probably going, if everyone in the refractive community got behind it, it'll be massive, and it'll be good for everyone.
Yes, it looks very impressive already. Andrea, how about you?
No, it was not in my consciousness, so I've learnt about that tonight.
Yeah, it's worth looking it up. And we've had another email with a question from a very young resident asking about any events, obviously events that you can attend in person once they are back on, or any online events that you would recommend, especially for future refractive surgeons or young refractive surgeons. Which are the best ones to attend? Andrea, maybe if we could start with you.
We discussed in our backyard the Australian Cataract Refractive Society meeting, so AUSCRIS, which is always held in a very beautiful location in Australia. So this year it was meant to be in Noosa, but unfortunately, due to circumstances, is cancelled, and it's now going to be a webinar. But every year it's in a beautiful, somewhere in the tropical North Queensland, usually, destination, and it's a small meeting, so that at the end of the day, you're having, your lunch next to one of the invited guest speakers, who happens to be, someone you normally see on a big podium, and you can have chats to them. And that kind of meeting, and it's very real. So you get the real, I think, like Ben was saying, people aren't afraid to talk about their complications because, this is how you learn from mistakes. And so I think people are pretty honest about their responses. And obviously ASCRIS and ESCRIS. I think ESCRIS is amazing for its new technology. I think all the new technology always gets first announced at ESCRIS, so that, those talks there are really pushing the new technology. And of course ASCRIS as well, like our American colleagues are amazing educators. So I think any of those meetings, and I'm sure there are a lot of other meetings as well, but those would be the main ones that come to mind.
Ben, what are your favorites?
I'm definitely with Andrea on the fact that AUSCRIS, the Australian meeting, not only do you get the chance to truly meet people that you've only seen on stage, and it's been amazing for me. There's also a trainee day that I help organize, and it's sort of things that maybe wouldn't be offered at a bigger meeting. So it might be this year we were planning a whole day on mindfulness and the sort of the mental side of surgery and refractive surgery, and things that might not be sort of routinely offered. I love that meeting. And then on the other side, in terms of my favorite meeting in the world, would be the European meeting, the ESCRIS. I just love it. I think that that's the latest. That's, if you want to organize to meet people, it's exciting. There's something about it. I think they would be my two picks. No offense to the American meeting, Ash, sorry.
Great, thank you. And Ashiyana, any local or international events that you would recommend?
I echo what my friends just said. The cataract and refractive surgery societies worldwide are your fountain for education. So definitely reaching out to their foundation, finding out what's going on, the meetings that are now going virtual, definitely attend those, whether it be ASCRS, ESCRS, Australia CRS. Go for all of it. If you're gung-ho and really want to learn about refractive surgery, do it. And the Refractive Surgery Alliance webinar series, go for that. But those are sort of the main ones I would recommend as well.
That's great. Thank you. Unfortunately, our time is running out. It was a great discussion. So thank you so much to our speakers for your insights, and to our audience for sending some questions. And I just wanted to let everyone know that the discussion will be also available on demand within the next few days, if you wish to revisit any of the topics that we covered today. And from everyone here at the Ophthalmologist, thank you very much, and we hope to see you again very soon.